my last lecture uh, for this. Yeah. This is my second time here already. So today we'll talk a little bit about pneumoconiosis, but not all of them, just like a couple of them, and then different manifestations. So it's not really common diagnosis unless you work in the occupational health, like specializing in the exposures. Like you will not be seeing this frequently. Once in a while, you'll have a patient, but it's pretty rare to see somebody with official diagnosis of pneumoconiosis. So we'll talk about a couple of them. So silicosis is going to be number one. We'll talk about acute and chronic, and manifestations are different. The pictures will be different. We'll talk about asbestosis, and then we'll discuss pleural diseases associated with the asbestos exposure. So asbestos exposure can give you different kind of problems, including parenchymal disease, pleural disease, cancer. So we'll just briefly review that. And just a few words we'll mention about malignant mesothelioma. So what is pneumoconiosis? Pneumoconiosis is a general term caused by inhalation of dust particles over a prolonged period of time. Sometimes it may not be so prolonged. If it's really high concentration, high density, it can be even like within weeks or months. So it causes inflammation and scarring in the lung tissue. Oh, one more, thank you. So the specific type of pneumoconiosis will depend on what you inhale, right? And then how much you inhale, what speed. So this is just like examples. Black lung if it's a coal, silica if it's silicosis. Silicosis basically sand is silica. That's the very abundant. It's everywhere. And asbestos, it was abundant at some point, like at the beginning of 20th century, maybe until 50s, 60s. But then it was realized that it's actually doing some harm. So it was eliminated from usage. So, good case. 56-year-old man was retired stone quarry worker. Quarry means like where you basically mining. You do to get the stones. Present with a 6 month history of progressive shortness of breath, initially occurring during the moderate exertion, but now present even with minimal activity. He reports a chronic dry cough that has recently become productive with whitish sputum. The patient also notes fatigue, unintentional weight loss, 6 kilograms, which is about 10 pounds, like 9 pounds, and occasional pleuritic chest pain. He denies hemoptysis or fever. So past medical history is only hypertension. Occupational is worked in stone quarry for over 30 years with minimal respiratory protection and frequently exposed to high levels of dust during stone cutting and crushing. He has a history of smoking for 20 pack year and then quit 8 years ago. Review of symptoms otherwise negative. His vitals uh, close to normal. Oxygen at rest saturation is 93%. He looks thin, short of breath at rest. Has a decreased breath sounds in upper lung fields, few crackles, fed bilaterally, no wheezing, normal heart sounds, no murmurs, no swelling in the legs, no edema. So that's his chest X-ray. So what do you think is happening? It's only two options. Yeah, so they're like kind of a little bit micronodular also. They're not like dense. They consist of a little bit resembles miliary TB, but miliary TB would present a little bit differently, like history-wise. So this looks like a silicosis, like chronic silicosis. Okay, uh, and then the most important part of the history is the exposure to silica, for which was prolonged. You remember, like he worked for over 30 years in this quarry mining, getting the stones. So he had a lot of exposure to the silica. So and eventually that's what happened. and we'll talk about that, but latency can be like decades. Uh, so we'll talk about silicosis is a progressive lung disease caused by inhalation of fine crystalline silica dust. It's a common mineral found in materials like sandstone, concrete, and mortar. Primarily affects workers in industries like construction, mining, quarrying, manufacturing, where exposure to silica dust is frequent and prolonged. So there are two forms of silica, right? There is amorphous, which is kind of a glass, right? And it's not that, it's relatively non-toxic. And there is a crystalline, which is actual sand, and other forms of the silica, which includes quartz, cristabalite, tridymite. To be honest, I didn't know about all these forms until I started preparing the lecture. So, and it was known for a while. So even in the like ancient Greek, like old days quarry workers, they were aware about this disease. So who is at risk? So where you can get exposed. So this is the sources of exposure. The old ones are there is a mining, quarrying, stone cutting, which and these professions, occupations, they've been existed like for hundreds of years, right, for thousands of years. So that's why you can find the evidence of disease in the old times. Construction work, sandblasting. A new one is a hydraulic fracking, which is like getting the oil, right? Then in sandblasting is fabrication and installation of the stone counterparts, coal mining, and then a few words about silicosis pathogenesis. So what happens? So in health, this is just proposed. I think that with a lot of silicosis, it's not 100% clear what happens because it's kind of difficult to study on the human. So a lot of them like animal models. Uh, so inhaled particles, they engulfed by alveolar macrophages. Silica is cytotoxic itself, leading to macrophage death because it's kind of it's a stone, right? So macrophage cannot digest it. It's not designed to digest the stone. It's can attack like live organisms like viruses, bacteria, but with the like silica particles, it doesn't work like that. So it triggers chronic inflammation, activation of fibroblasts and collagen deposition. And then what you see on the X-ray at the beginning is the formation of fibrotic nodules in the lungs. And then as the time goes, it may go into fibrosis. So this is primarily for the chronic silicosis, okay? So again, this is the picture which I described. So here, for some reason, there is a some if this lipopolysaccharide. So somehow it's a part of the pathophysiology that it primes the cells for this inflammatory process. Priming means like previous exposure to lipopolysaccharide, which is the bacteria, will activate some processes which make you more likely to get inflammatory response to silica. Okay, so when the silica particles get into the cell, they form phagosome. There is a lysosomal damage again because they cannot digest it. Uh, Oxygen particles, they with the help of NADH, they create the protein complex called inflammasome, uh, which includes different proteins and enzymes. ASC is apoptosis associated spec-like protein, right? So, and then caspase is activated. That increases the level of interleukin 1 beta and then 18. It looks like similar, but it's a different. Like one is 1 beta and one is 18. So, and then inflammation happens. It clinically manifests as the nodules, shortness of breath, fibrosis later. So these are the types of clinical presentation of silicosis. So if it's a high exposure in the short period of time, people would develop acute silicosis. And another name for that is the silicoproteinosis. So it looks like a alveolar proteinosis, right? There's another diagnosis, another disease, but clinically it looks something similar. And then if there is a lower dose and exposure for a longer period of time, then patients will develop chronic silicosis, which comes in two different forms. At the beginning, it comes as a simple silicosis, but as the nodules coalesce together, they form progressive massive fibrosis. So, like 10 small nodules become like 2, 3 big ones. And accelerated silicosis is it's close to chronic silicosis in terms of pathogenesis and presentation, but the latency is a little bit less. So it presents in about 10 years after exposure. So acute silicosis, right? So uh, it's typically seen with the higher levels of exposure, and latency could be even a few weeks. So if you get exposed to high dose, like 1 month later, this may be presentation. So it's a rapid onset of patients will come with a rapid onset of dyspnea, cough, weight loss, sometimes pleuritic pain and fever. And then in general, you need to know from the main message for the lecture is that you need to take occupational history for the patients like this. So and that's essential part of the evaluation. And then if you ask the questions, you'll reveal exposure history to silica. Okay. So in terms of labs, there is nothing specific. You would do like CBC electrolytes, whatever you think is essential, like BNP, EKG, uh, and then but nothing specific. So you'll see how much oxygen patient requires, if requires any. Uh, so like you'll evaluate hypoxia basically. You can do different ways. You can do pulse oximetry if it's simple, or you can do like ABG to see the full panel. So on the X-ray, as on the previous chest X-ray, you'll see. Actually, no, this is different. This is acute silicosis. So you'll see bilateral diffuse ground glass opacities. So ground glass means it's not dense enough, like to cause the all whitening, and it's kind of haziness. Okay, on the chest X-ray or on the CT scan, that's what called ground glass. On the chest CT, you'll see basically the same, but in better picture, you'll see again ground glass opacities, patchy consolidations, crazy paving patterns, and I'll show you the picture how it looks. Uh, if bronchoalveolar lavage is done, that will help to exclude infections, eosinophilic pneumonia, alveolar hemorrhage. So a lot of tests in general we do not only to diagnose, but to exclude other possibilities, uh, primarily infection in these patients, because a lot of atypical infections may look like the same. Biopsy usually not necessary, but if you do, you'll see proteinaceous material filling alveoli, which will be PAS, which is a periodic acid shift positive. You remember alpha-antitrypsin deficiency will also stain positive for the PAS in liver. So it's just one of the stains used to identify. And unfortunately, there is no good treatment. It's supportive. The steroid's not going to do much. If somebody would qualify and there is a donor, like they can say the lung transplant, but prognosis is poor. So if you come with acute, somebody comes with acute silicosis, it's not good. So that's how it go. How that's how it looks on the chest X-ray. Again, this is not specific, right? That's how it may look, but if patient comes with this chest X-ray, it doesn't mean it's silicosis if there is no exposure history. You see bilateral like reticular opacities. They're not super dense. You can see a little bit ground glass. There's no effusion. So that's how chest CT may look like, kind of patchy. So you have a little bit of the, I would say like this is just normal, close to normal lung tissue. And this would be like called something like ground glass, okay? When it's not white, it's a bit grayish, but it's not normal. And that's what I mentioned about crazy paving. So on the right lower corner, you see kind of random paving, which is used to make the fence or make the trails. So, and then it looks like for somebody it resembled like this crazy paving on the CT scan. That's how the name came. So you can see the same also. It's kind of the same random way. There's areas of relatively preserved normal tissue, but most of it's affected. So what are you going to see on the microscope? you see here on the left, you see the lung tissue alveoli, and then instead of being normal alveoli with this air space, you'll see this pinkish uh, proteinaceous material which fills up the lung. And then if you increase the magnitude, then you'll see like tiny granulation, which you can see on the picture on the right. So chronic silicosis, okay? So latency is longer. So it usually takes like 20, 10 years, sometimes 30 years after prolonged exposure. And then, as I mentioned, accelerated silicosis is it's close to chronic in terms of clinical presentation, but it happens 5, 10 years after of exposure. And chronic silicosis could be asymptomatic. If it's simple silicosis, you have few nodules, but they may not necessarily cause symptoms, and you may find them like if you do X-ray for something else. But if it's progressive, patients will have dyspnea, cough, crackles, bronchi, wheezing, maybe hurt. And again, in terms of labs, there is no specific test, uh, but may need to rule out TB, both latent and active, depending on the symptoms. So chronic silicosis continues. So you remember we're talking about restrictive lung diseases. So that's why PFTs will be suggesting more restriction rather than obstruction. And then depending on the what pathologic process is predominant in specific patient, you'll see different changes. So you usually would see normal spirometry again because there is no bronchial obstruction. You will see decreased total lung capacity, decreased. You may see sometimes a little bit decreased FEV1 to FEC obstruct if there is obstruction. And then PMF is a progressive massive fibrosis when as I mentioned, like the nodules get together, they become like extensive, and then you will see decreased diffusion capacity for CO2. On the chest X-ray, you will see multiple small rounded opacities in simple silicosis. And then as it progresses in the progressive massive fibrosis, these opacities enlarge, get together, coalesce, and again, you'll see bigger irregular opacities. May see also hilar adenopathy and calcifications. So, and then you'll see the same on the CT scan, and then you'll have a better picture of the lymph nodes. On the biopsy, if you do it the right spot, you'll see silicotic nodule with a central hyalinized pearl, like kind of curvy collagen, which is surrounded by the more regular collagen fibers, and it's going to be birefringent. If you lose light microscopy, birefringent means the light going through the crystal goes into two different rays. So that's what it means by birefringent. So, and they use polarized light microscopy. Polarized means they put the filter and then the light wave is only on one surface. Okay. And again, unfortunately, there is no proven specific therapy for the chronic silicosis. That's how chronic silicosis may look like. You see a little bit kind of nodularity, but otherwise, it may not be super impressive. This is a more impressive picture when patients present at later stage. This is progressive massive fibrosis. You see the multiple small nodules, they became few big ones. And then if you just see the X-ray, again, it can be anything. Like it can be sarcoidosis, potentially it can be, but it would be unusual to be cancer look like this, because if the cancer gets to this stage, they're usually much more symptomatic. Um, so, and then again, on the CT scan, that's what it's going to look like. It's the same patient. It's just like different. You see here more like hilar mediastinum, and then here on the right one, you see more like lung tissue, but it's the same imaging. You can see a little bit of calcification. White, the calcium will look white on the CT scan, and the contrast also looks whitish. So, but there's no contrast here. So you see calcifications in the tissue, in the hilar lymph nodes. That's why the left one is a different protocol, right? And then on the right, you see consolidation with you see few air bronchograms when there is like small airways and the consolidation around. It's not specific for the silicosis. Usually you see it with pneumonia because airways stay open around the dense lung tissue. So that's how the silicotic nodule will look under microscope. You see the whorled kind of more irregular center with the collagen and more regular circles around. And then the right lower corner shows the polarized microscopy. It's a birefringent crystals, like tiny one. That's the crystals, okay? You see two different colors there. So if somebody has a silicosis, they're unfortunately also more prone to have other problems. And then tuberculosis, TB, which we talked a few days ago, is one of them. So if somebody, for example, has a chronic silicosis, but one day come with new symptoms like fevers, coughing up blood, may, and then especially if there is a cavitations on the imaging now, then that's what you need to rule out. Uh, Silicosis also will predispose patients to the lung cancer. It's associated with the connective tissue diseases like scleroderma, rheumatoid arthritis, also with vasculitis, and then chronic kidney disease. So another case, 78-year-old man reports gradually worsening breathlessness, has no relevant medical history of note, and has never been a regular smoker. His spirometry reveals both FV1 and FVC about 50% of the predicted values. The machine interprets this as restrictive. In his 20s and 30s, he spent about 15 years working in the boiler room, so of power station. And the chest X-ray reveals several pleural plaques, some calcified, but no abnormalities. So what what's happening here? So what do you see on the chest? What do you see on the chest X-ray? So we see problems on both sides. Kind of irregular shape. You see irregular shape on the left and on left and the right. Irregular shape uh, of haziness with a more like sharp borders, right? The left one is more clear, and you have something similar on the right, but the borders are not so clear. So it's you can see this is the pleural plaques from asbestos exposure, and then patient because he has symptoms of, and then abnormal PFTs probably has some pulmonary fibrosis as well from asbestos exposure. And if you look in the history, he worked in the boiler rooms. So boiler rooms, like in the past, they used the like asbestos to kind of cover the things uh, as the insulation. Okay, so the heat, the cold doesn't go through. So asbestos-related pulmonary diseases, there are a few of them. Um, Asbestos is a general term for the group of fibers composed of hydrated magnesium silicates. And there are two different types of fibers of asbestos. One is the serpentine, which is long and curly strands. And then there is amphibole, which is long, straight, rod-like. So it's just the types of how the asbestos can be seen in nature. So serpentine is only one of them. Is a chrysotile. So I don't think we need to remember all these specific names, but just interesting to know. Uh, so serpentine is one of them, and then the rest are amphibole, okay? Types of the asbestos. So, and then asbestos exposure can give different diseases. So asbestosis itself is a problem with the lung parenchyma, okay? It's a slow progressive diffuse pulmonary fibrosis. If somebody has idiopathic pulmonary fibrosis without asbestos exposure, those patients usually progress much quicker. And asbestosis is a slowly progressive disease, okay? And many times people would die from something else before they get really like seriously hypoxic to die from asbestosis. Um, it also can give pleural disease, which can be benign and present in different ways, like pleural plugs, as we've seen. It can give diffuse pleural thickening and benign asbestos pleural effusion. And it can be malignant, and everybody knows about mesothelioma, which is clearly associated to the asbestos exposure. So, which occupations are at risk? Uh, Plumbers. So again, a lot of these exposures they happen because asbestos has been used like for hundreds of years, and it's not. I don't think it's manufactured or used anyway actively. Uh, but because there's all houses, all buildings, these people still may get exposed to asbestos, which includes plumbers, pipe fitters, electricians, insulation workers, carpenters, again, boiler makers, welders, and cutters. So, and then in which industries you may get exposed to asbestos is, of course, construction is the most common, uh, especially if you're like demolishing old houses or like do remodeling, then you get exposed to asbestos. It's also shipbuilding and repairing, chemicals and nano manufacturing, non-metallic mineral stone products, railways, thread and fabric mills, trucking, plastic and rubber manufacturing. So a few words about the genesis. Uh, so first, what happens first? First, there is exposure, right? So you inhale the asbestos. Uh, it gets into the lungs, in the alveoli, bronchioles. Uh, then the fibers get deposited there, and then it causes uh, inflammation. Macrophages get attracted there through the bloodstream. Uh, Macrophages again will try to digest the asbestos fibers. This will create problems because they really cannot digest the asbestos. So reactive oxygen species like hydrogen peroxide, active oxygen will form. This will attract. This will cause inflammation, attract fibroblasts, all other cells, which will cause collagen production, fibrosis, and tissue damage. And if it affects the mesothelial cells, may cause the cell damage, DNA damage in the mesothelial cells, in the pleural space, and then cause the mesothelioma. So, so a few words, just like quick summary of pathogenesis. Again, it's inhalation, deposition of asbestos fibers, activation of alveolar macrophages, phagocytosis of fibers, release of pro-inflammatory cytokines, persistent inflammation, generating free radicals, oxidative stress, causing DNA damage, and then this causes fibroblast activation and production of excessive collagen, causing fibrosis. So in general, the production of fibroblasts like collagen is kind of protective reaction. If there is any damage, your body try to kind of wall off the problem area with the collagen. But if the process goes too much, then the damage happens to the body itself. So that's how asbestos will look. This is asbestosis, though this is pretty advanced case. You see the autopsy of the lung on the left side. Uh, you see the honeycombing. There's areas like open areas in the lung, and then on the right here you can see the asbestos bodies. So this is asbestos bodies, and then asbestos deposits. So the right picture has one, like the up and low. Low is a bigger picture. It's more increased in magnitude. So what you're going to see if you take a tissue on the gross anatomy, you'll see stiff lungs with fibrosis in the subpleural regions of lower lobes, and then the fibrosis may involve the pleura itself as well. And then at the microscope, you'll see asbestos bodies and interstitial fibrosis, similar to usual interstitial pneumonitis, which is basically means pulmonary fibrosis. and then fibroblast foci are rare in asbestosis and more abundant in the idiopathic pulmonary fibrosis. So again, comparing to idiopathic pulmonary fibrosis, this is a slower process. Okay, this is not super quick acceleration of the problem. That's why you see less fibroblasts, you have less activity. But in idiopathic pulmonary fibrosis, it may look similar, but it's a more active process, and then patients decompensate quicker. So how the patients would usually present? Again, as with many pneumoconiosis, the latency, which is the time from exposure to the symptoms, could be up to 20, 30 years, depending on the intensity of exposure. Uh, and then they come with gradual and progressive shortness of breath and exertion. Nothing specific on exam. You can hear crackles, some signs of pulmonary hypertension in advanced cases. In the PFTs, you'll see reduced lung volumes, decrease the diffusion capacity for the CO2, usually no obstruction. So because you have less lung tissue, that's why your capacity to diffuse oxygen or like any gases will be decreased. So on the imaging, you'll see bilateral multinodular reticular opacities. Pleural abnormalities may be seen, which should be frequently seen. Interstitial process begins in lower lungs, and then comparing to silicosis, hilar and mediastinal lymphadenopathy will not be seen on the imaging. And chest CT is more sensitive. So, and then 30% of in a lot of patients with asbestos exposure, the chest X-ray will be normal, but 30% of them still will see, you can see some abnormalities on the chest CT. You'll see subpleural linear densities, fibrosis, which may involve different areas. You can see parenchymal bands, which is also related to fibrosis. And then more advanced cases, you will see honeycombing. Honeycombing means on CT, you see what the kind of the lung with the holes. Okay, I'll show on the next picture. So that's how it may look. You see more lower parts of the lungs involved. There is like haziness here, which again looks like the pulmonary fibrosis. You also can see the heart is a little bit enlarged. It's beyond the mid-clavicular line. And then upper lobes are a little bit less involved. So that's what CT may looks like. You see this is the lower lobes. You can see a little bit fibrotic changes there and the small areas of honeycombing. When this pathology spreads throughout the lung, patient usually have the more advanced disease. So a few words about the pleural disease associated with asbestos exposure. So again, it can be benign and it can be malignant. So we can see pleural plaques, which you saw on the chest X-ray. Most of the time, pleural plaques will be like asymptomatic. You'll find them on the screening chest X-ray, or if X-ray is done for different reason. Sometimes they may cause a little bit pleuritic pain. Usually wouldn't cause any shortness of breath. Um, so also another pathology you may see with the pleural disease is a diffuse pleural thickening. So again, a lot of patients may be asymptomatic, but if you do chest CT and you see the pleural is thick, this may give sometimes a little bit shortness of breath, some pain, and then remember all of this is a benign, so you don't have. It's just usually doesn't require much action from you. Also, you may see benign asbestos pleural effusion. The short term is BAPE, benign asbestos pleural effusion. So if the effusion is a little bit bigger, patients may have shortness of breath, may have pleuritic chest pain. On the chest X-ray or CT scan, you may see pleural plaques. Few of these may come together. Okay, so may have pleural plaques, which will suggest asbestos exposure. On CT scan, you'll see effusion, and then if you're concerned about malignancy, you may need to do pleural like thoracentesis just to rule out other pathology, and then you'll do cytology. So you know what cytology, right? Cytology. What's the difference between cytology and biopsy? So biopsy, you actually have you go with the you can open biopsy, you can do the fine needle aspiration, and then you'll see the structure of the tissue, right? You'll see how the cells like stand to each other, what is the connections between the cells, and then you can run different mod tests like different genetic tests on the tissue. Cytology, it's usually what it's done. You take the fluid, you spin it, and then the cells go one direction, and then fluid goes another direction, and then you analyze the cells in the microscope. You still can do different stains, like for different cytokeratins, like you can see what kind of cell is it, right? But the cells kind of freely floating, and then they're not linked to each other, so you don't see the structure of the tissue. So that's why cytology is many times is good enough to rule out or make like preliminary diagnosis, but not always sufficient, like to decide about treatment. And then malignant is a mesothelioma, which we'll talk in a minute. So here's the example of the pleural disease. It's the same patient. On the left, you can see pleural effusion. Uh, so normally it should be like this. You should not see any pleural fluid normally. Here, this is the space which is taken by the fluid. Uh, it's about the thickness of the chest wall, and potentially can be tapped, but it's not big. And then the same patient, 6 months later, you see the effusion is gone, but you can see the pleural thickening there with arrow, and then just the pleural looks a bit thicker. I don't think the patient get any treatment; it just resolved on its own. So a few words about mesothelioma. It's strongly associated with the exposure to asbestos. It can arise from pleura, which is the most common, uh, and then in 75-85%, it does arise from pleura, but it may arise from other linings as well, including peritoneum, pericardium, testicular tunica vaginalis, which is very rare. And only a small proportion of asbestos exposed individuals will develop mesothelioma, like 2 to 10%. So this disease is getting less and less common because the exposure to the asbestos is not so common these days. And there are different mechanisms of development. It's DNA damage through reactive oxygen species, tumor suppressor genes inactivation, and oncogenic pathway activation. So when you talk about tumors, there's two different types of the pathways, right? Some of the genes and then enzymes, they work as a tumor suppressor. So if you turn off them, then the cells has unregulated growth. And there is oncogenic pathways, which if they overactivated, then the tumor also may happen. So patients would usually present with a shortness of breath. You will find pleural effusion. And then it may have like circumferential involvement of pleura on imaging. And then you'll need to do with any malignancy, any like oncologic disease, you need to you need to have like tissue diagnosis. Almost all of them. So you'll first, the easiest thing to do is a pleural fluid cytologist. So you do thoracentesis, uh, take the fluid and see if there is any cancer cells there. The problem with the pleural fluid cytology, it's not very sensitive. So even if there is a cancer there, like in the pleural cavity, it still may come negative. So that's why sometimes you need to do not only with this diagnosis, but if you think about any metastatic disease to the pleural cavity in mesothelioma as well, there is a still significant chance that you'll not catch these malignant cells on the fluid. Um, that's why you may need to do the biopsy of the pleura, which is a little bit more complicated because you may need to do uh, like video-assisted thoracotomy, like small incision, go with a camera, take a biopsy, and then may do PET CT as well. You know what is PET CT, right? So basically, it's a it's a CT scan combined with a special radionuclide uh, substrate, which shows the metabolic activity of the tissue. So if there is a in cancer cells, in any cancer, there will be higher metabolic activity comparing to normal tissue because they're dividing, right? It's not 100% specific. Sometimes if there's infection, it will have increased metabolic activity as well. But if you do PET CT, then you'll see that the tumor will just be like more bright, okay? So that's about diagnosis. And then unfortunately, prognosis is poor because patients usually, it's kind of difficult just to surgically cut off the mesothelioma because it's in pleural cavity. It's usually spread. Usually there is a metastasis by the time it's diagnosed. And patients could be not like good surgical candidates. So overall prognosis is not good. So I think that's it. So just to summarize, like we talked about silicosis, right, which happens as a acute and chronic, and we talk about asbestos exposure, which may cause the slowly progressive pulmonary fibrosis, and then can cause the pleural disease. Okay, so I think that's it for questions. Okay, thank you.